Hello, everybody. I'm Dr. Tom Pitts, a board-certified neurologist, board-certified clinical neurophysiologist, a multiple sclerosis certified specialist with added qualifications in headache medicine from the National Headache Foundation, and a proud Myasthenia Gravis Foundation of America partner provider. I thought I would roll out a very interesting disease state here that has a fascinating and ever-growing research treatment landscape. And that disease also, as a neurologist, happens to be my passion, my favorite disease of all diseases to treat. The reason why, well, you can really help these folks out when they would otherwise be potentially in a very bad or life-threatening situation. This disease is myasthenia gravis. It is the most common neuromuscular junction disorder. However, it is still a rare disease, meaning it affects less than 200,000 people in the United States. To date, there are approximately 65 to 70,000 known myasthenia gravis patients. This disease can be elusive and very clinically challenging. MRIs are not helpful as it's a problem in the peripheral nervous system versus the central nervous system, which is the brain and spine. So you really have to use your eyeballs and clinical judgment here. Making this disease more complicated to diagnose, there is a fluctuating pattern of weakness that is better in the morning, typically getting worse subtly over the day, and then also with repetitive movement, patients become more weak. So there is approximately a 5 to 7 year delay in diagnosis. So while there are potentially 65 to 70,000 known patients, there are probably many more worldwide suffering without a diagnosis as of yet. So I mentioned a neuromuscular junction disorder. What does that mean? And let's talk about myasthenia gravis. Well, myasthenia gravis, translated literally, is the grave fatigue. And it was classified as far back as the 1400s. Samuel Wilkes, Mary Walker, actually the first person to administer a medicine, Pyridostigmine, to a patient, I believe in the 1800s. So, this disease has been well classified. It is a neuromuscular junction disorder, which is the communication between the nerves and the muscle, right? Your brain says, I want to move my hand. A message comes down all the way, right, from the motor cortex all the way down to the spine and then out to the nerves. The nerves then have to cross a synapse, an anatomical cliff, if you will, nerve muscle. They shoot a neurotransmitter called acetylcholine. It's like a messenger. If you were on the other side of a cliff and we couldn't talk to each other verbally and I had to tell you something and I had to throw an airplane or a paper airplane over there with the message on it, that's kind of synonymous here to acetylcholine, a neurotransmitter, paper airplane. So it goes from the nerve, it carries the message from the nerve, move hand, across the neuromuscular junction to the muscle, and it has a parking space. It's called an acetylcholine receptor. It parks there. The muscle reads it and says, oh, move. And you get a voluntary motor muscle contraction, right? Obviously, that happens lightning fast here. But that being said, that is it broken down. In this process, you form antibodies to your own neuromuscular junction, meaning this is an autoimmune disorder. This is dysregulation of T cells that are normally weeded out in the selection process in the thymus, amongst other areas, a gland in the chest. That are autoreactive, meaning they recognize you as a bad guy, are usually weeded out. Like when you're picking strawberries or some other fruit, you find a bad one, you toss it, right? So similar stuff should happen in the immunological training process in any human being. That being said, this process is corrupted in myasthenia gravis and all other autoimmune diseases, usually due to something called an HLA haplotype mutation, which is common between the autoimmune diseases, which is why these folks, myasthenia gravis, just like most other autoimmune patients, have concomitant or comorbid other autoimmune conditions. They may have rheumatoid arthritis and myasthenia gravis and Hashimoto's and diabetes type 1, for example, or lupus or Sjogren's. So these folks, unfortunately, develop autoimmunity. Autoreactive T cells are allowed to pass through and thrive. They basically corrupt the training camp, the thymus. They start to teach new T cells how to be bad or how to attack you. And then that activates B cells to turn into plasma cells, which then activates something called the complement in acetylcholine receptor antibody positive myasthenia gravis. The complement is an immunologic megasoldier. It then attacks the neuromuscular junction, destroying the motor end plate of the muscle and causing very grave weakness. This can cause problems with talking, chewing, swallowing, breathing, eyelid droop, which is known as ptosis with a PT, diplopia or double vision, arm and leg weakness, head drop, and then that can lead to downstream problems like inability to drive, socialize, work. You're often hospitalized. You can be ventilated, meaning you need a breathing tube or life support because your diaphragm gives out. This is not a disease of the lungs, but the muscle, the diaphragm that controls the lung, can be weakened in this process, and it can be hard for patients to move the lung to breathe. So imagine an accordion that nobody's pushing on. So we have broken this disease down further into antibody subclasses and by age or genetic or non-genetic predisposition. So at the 10,000 foot level, we always break it into the transient neonatal form, which is when, mom gives the baby her immune system for about 6 months while the baby develops theirs. If the mom is a myasthenic patient and the newborn is born, even though the newborn will not go on to be a myasthenic potentially, they may have mom's immune system for 6 months and thus be a myasthenia gravis patient for 6 months. There's the pediatric form, which is autoimmune. It may spontaneously go into remission at puberty, although not always. And then if it goes into remission at puberty, it tends to stay in remission in the kids. In adults, there are two main groups. Mainly 2/3 in the first group are younger women, 20 to 40 years old. I tend to refer to that as the autoimmune alley because that's where you find a lot of problems with autoimmunity. Young women like lupus, Sjogren's, thyroid problems, whether it's Graves or Hashimoto's. I mentioned diabetes type 1. So this is kind of the autoimmune alley. And then the second motor group of patients are relatively older men, anywhere from 50 to 80. So there's a bimodal distribution in adults. And then furthermore, we want to recognize that there is a congenital form that is genetic, extremely rare, and there are all different types of mutations there, including things like the Rapsin mutation. Each one of those has a different diagnostic and treatment consideration and a landscape in the investigation or research world. Now, break it down further, whether you're talking about any of the groups except for the congenital group that doesn't have an antibody because it's genetic, not autoimmune. Any of the autoimmune myasthenic patients are going to have autoantibodies. And it's interesting. They are now starting to FDA trial these medications for the myasthenia gravis syndromes based on the antibody subclass because they activate different parts of the immune system. So the drugs have to modulate that specific part of the immune system only. So you look at the drugs of yesteryear, they were not FDA approved, things like IVIG, things like azathioprine or mycophenolate mofetil, known as Imuron and Cellcept respectively, tacrolimus, now second line, but methotrexate, and then the procedure plasmapheresis. None of these are FDA approved for myasthenia gravis, right? They've been grandfathered in for decades and they do work. We have consensus evidence anecdotally that they work, but it is nice to see this new wave of drugs coming in and getting FDA approval. We always have pyridostigmine, which is a symptomatic acetylcholine esterase inhibitor, which allows acetylcholine, that paper airplane carrying the message, to move to linger a little longer and facilitate movement, but it doesn't stop autoantibody production. That is FDA approved, however. Next came Soliris or eculizumab in 2017, which had already had 2 other FDA approvals at the time, one for atypical hemolytic uremic syndrome, or AHUS, and the second one is paroxysmal nocturnal hemoglobinuria, PNH. And then later, after the myasthenia approval in 2017 for adult generalized acetylcholine receptor antibody myasthenia gravis, which I'll explain in a second, it also subsequently gained approval for another autoimmune disease that is similar to multiple sclerosis called neuromyelitis optica, or Devick's disease. And again, it follows suit, right? It is approved for a specific antibody even in the neuromyelitis world. It was approved for adult aquaporin 4 channel antibody positive neuromyelitis optica. So that being said, the antibodies are not the disease, right? They direct a certain part of the immune system, and we want to know the antibody subclass in any autoimmune disease because we want to know what part of your immune system is going to attack you so we can line up a drug or medication and just modulate that part of the immune system, right? So there are acetylcholine receptor antibodies, which are the most common in myasthenia gravis, comprising about 85% to 90% of the patients. Then you have the MuSK, muscle-specific tyrosine kinase antibodies, comprising about 8%. And then there's LRP4 antibodies, recently discovered, comprising about 1% to 2%. And then the rest of the patients are what we call seronegative, meaning there's probably some other antibodies there. We haven't discovered them yet, but they clinically look like a myasthenic. And then that brings me to my next topic, the electrodiagnostic capabilities. So we can diagnose this disease clinically by looking at I mentioned fatigable weakness, right? So you can have a patient look up for long periods of time and you'll notice that their eye will fatigue or they'll start to get double vision, which is what happens when your eyes don't move perfectly in concert. If one is weak, they're off-centered and you get competing images and your brain forms a double vision, which is fixed or corrected when you cover either eye, which is like having two singers off key and then muting one of them. The song sounds normal no matter who you mute because they're both singing fine. They're just off key with each other. Same thing with the eyes, right? So that's an eye muscle problem. You could have problems running out of voice in the middle of a sentence and having to take a breath and start over. You can run out of breath while talking. You can have trouble chewing. You can actually lose masseter and temporalis chewing muscle power and actually just be stuck with food in your mouth and your jaw won't move anymore. Your head can drop and you can have trouble picking it up with the muscles like the splenius capitis and neck extensor can become weak. Your head can drop, causing musculoskeletal problems, disc bulges, radiculopathy or pinched nerves raining down the arm, headaches, sleep disruption. And then furthermore, this disease, when you talk about the seronegative group, that is a huge area of research, by the way, I want to mention, because we do need to discover these antibodies. We found the main reason why we're targeting antibodies is we used to have acetylcholine receptor antibody patients, and we just thought like, okay, everybody else is seronegative, and then there's all these myasthenia drugs. Well, when we found the MuSK antibody, and approximately 50% of the seronegative myasthenia patients at that time were found to be positive with MuSK, we found that MuSK expresses immunoglobulin or IgG4 on the antibody. It does not activate the complement. It activates a different cell line, mainly B cells, which is why a drug called rituximab has kind of emerged as the community favorite for this. It's a B cell depleter, just like Ocrevus or ocrelizumab in the multiple sclerosis world. Now, that's very different than acetylcholine receptor antibody disease that about 85 to 90% of patients have. Why? Well, acetylcholine receptor antibody disease expresses IgG1 and 3, which activate the complement. So you would use a complement inhibitor or consider one like Soliris, which is why Soliris is FDA approved for adult generalized acetylcholine receptor antibody positive myasthenia gravis, because it activates the complement, and Soliris is a complement inhibitor. Soliris would not, or eculizumab would not work for MuSK because it's IgG4 and doesn't activate the complement. So that's where we're going with autoimmune disease. So you look at the treatment landscape for myasthenia gravis, and it's exciting because now we have all these medications are getting FDA approval. So no more like being grandfathered in. It had a role. It's a rare disease, hard to run big trials. But you know what? I think the standard for safety and efficacy and predictability is always a good trial. And that's why I like that the new wave of drugs are going into this with FDA approval in mind. So I mentioned Soliris or eculizumab is FDA approved. I mentioned pyridostigmine or methicillin is FDA approved, but symptomatic, not disease modifying. So the ones that are coming in that are FDA approved, there's a class of medicine called the FcRn receptor antagonists, working similarly but slightly different to IVIG. These medications are being looked at for acetylcholine receptor antibody disease, MuSK, a disease called CIDP, chronic inflammatory demyelinating polyradicular neuropathy, which is like a chronic Guillain-Barré or peripheral nerve attack, autoimmune as well. There are multiple companies in the mix here that have started to produce these. Companies like argenx, Alexion, the UCB Raw, Momenta, Immunovant. So there are a lot of companies creating these FcRn receptor antagonists. And then also the UCB Raw team has Zolocaplan, which is a subcutaneous injectable complement inhibitor as well. And then Alexion has Ultomiris, which Solaris, their IV medication, which is a complement inhibitor, after a loading dose period of a week, you are given you are given it once a week for 4 weeks as a loading dose, Solaris, and then every 2 weeks after that, a 35-minute infusion. They've created Ultomiris, which will be every 8 weeks, a complement inhibitor that's IV every 8 weeks. So very exciting treatment, landscape. And this is so vital because these patients, folks, can end up on a ventilator. Many of them have to be hospitalized for long periods of time in the ICU. If anybody's ever been sick in that situation, it can be financially devastating. And your work has to be extremely accommodating of all these, the rehab and the hospitalizations and the infusions. And that can put a strain, that can leave somebody with no vacation days at all. Like they have to use all their vacation days. Well, what do they do when they're, they want to take their kiddo on a trip or something or do something with the family? I mean, it really stinks. So it's a horrible situation for folks that have secondary and tertiary symptoms. Like, for example, they may have problems chewing from the weakness. That's the primary symptom. Thus, they may develop a dental hygiene problem. That's the secondary problem, the dental issue. Then, because of the dental hygiene problem, they may not want to go socialize with people and become depressed. That's a tertiary symptom. Everything that this disease does is very bad, and it's extremely nice to see such robust and an ever-growing treatment landscape directed at the specific antibodies, guys. That's the key of autoimmune function or disease, lining up the antibody. Remember, an antibody in your blood does not confer the disease upon you 100% of the time. There are people with antibodies that don't attract the immune system yet. Things that heighten the immune system, like any surgical procedure or any new medication or an infection can provoke or unmask a previously dormant autoimmune disease. So that being said, I'm very proud to report about Myasthenia Gravis, which is, again, my favorite disease because I've had the honor of getting people off ventilators using immunomodulating techniques and having them walk away and then later go into remission, see them dance at the wedding, see them, hit the home run, see them continue working and just enjoying life. It's the most fulfilling thing you can do as a physician. And then to see attention to this disease and the way it's been drawn, largely due to foundations like the Myasthenia Gravis Foundation of America, it's really heartwarming. And then to see this really organized treatment landscape to go from these kind of grandfathered in anecdotal class C level evidence treatment approaches into a level 1A, double randomized placebo, control trial is really wonderful, and it's the way it should be. So I appreciate everybody joining me. We look forward to speaking to you guys frequently. I cannot wait to keep everybody up to date on the latest and greatest in the healthcare world. So for Trial Site News, I hope you all have a wonderful day from Manhattan, New York, United States of America.